Hi everyone, and welcome to Module 9 of our course, Vascular Ulcer Management. Now, vascular ulcers might sound like just another category of wounds, but in practice, they're some of the most persistent, painful, and misunderstood wounds we encounter, especially in older adults or patients with diabetes and circulation issues. In this module, we'll break down exactly what causes these ulcers, how to tell one type from another, and what you, as a nurse, can do to not only treat them, but help patients avoid serious complications like infections, hospitalizations, or even amputations. Let's jump right in. Before we start, here's what you'll be able to do by the end of this session. First, you'll be able to clearly differentiate between venous and arterial ulcers, not just the textbook definitions, but how they actually look, where they're found on the body, and how patients typically describe them. Second, you'll know how to perform a focused vascular assessment. That means knowing when to check an ABI, what to look for on the skin, and how to evaluate pulses properly. Third, we'll explore evidence-based care techniques, from choosing the right dressing, to when to use compression therapy, to identifying when it's time to refer the patient to a vascular surgeon. And finally, one of the most important parts, we'll talk about how to educate patients and their families so they understand how to prevent ulcers from coming back. Because let's face it, healing the wound is one thing, but preventing recurrence is the real win. So, let's start with the basics. What are vascular ulcers? Put simply, they're chronic wounds caused by problems with circulation. There are two main culprits here. Either the blood can't get back up to the heart, that's a venous problem, or the blood can't reach the tissues in the first place. That's an arterial problem. These ulcers are not rare. We see them all the time in patients with varicose veins, heart disease, uncontrolled diabetes, obesity, or a sedentary lifestyle. We typically deal with two types: venous stasis ulcers, which are caused by venous insufficiency, meaning the veins can't return blood effectively. Arterial ulcers caused by peripheral arterial disease, so the tissues just aren't getting enough oxygen and nutrients. Now, here's the important part. These wounds might start off small or not too bad, but without the right care, they can rapidly deteriorate. Some even lead to serious infections or amputations. That's why early detection and proper classification are absolutely key. And that's where your role as a nurse becomes so powerful. All right, let's zoom in on venous stasis ulcers, or VSUs. These are the most common type of vascular ulcers, and they're directly linked to chronic venous insufficiency. Here's what's going on inside the leg. The veins, especially in the lower leg, have valves that are supposed to push blood back up to the heart. But when these valves become weak or damaged, blood starts to pool in the lower extremities. This increases the pressure in the veins, causes fluid to leak into surrounding tissue, and eventually leads to skin changes, and then ulcers. So, how do we diagnose a venous ulcer? First, we do a clinical assessment. Look for swelling, varicose veins, and any skin discoloration around the ankle area. Then comes the ABI test, the ankle brachial index, to check arterial circulation. We need to rule out peripheral arterial disease before starting any compression therapy. An ABI between 0.9 and 1.3 is considered normal. If it's lower, we need to be cautious. We might also order a duplex ultrasound to check the blood flow through the veins. Now, let's talk about what these ulcers look like. They usually show up above the inner ankle, the medial malleolus. They're shallow, have irregular edges, and tend to ooze a moderate to large amount of fluid, so you'll often see a lot of exudate. The surrounding skin might look dark brown or purplish due to hemosiderin deposits, a result of iron leaking from red blood cells. You may also feel areas of firm, tight skin. That's called lipodermatosclerosis. One more clue: the pain. It's usually described as a dull ache, and interestingly, it gets better when the leg is elevated. And here's a key detail: pulses are usually present. That's a big hint that we're dealing with a venous issue, not an arterial one. So, to summarize, VSUs are about poor return flow, fluid overload, and skin breakdown. Recognizing them early sets the stage for successful, evidence-based management. Now that we understand what venous ulcers are and how they present, let's talk about managing them. First, compression therapy is the gold standard. Why? Because the root problem is blood pooling in the veins. Compression helps push that blood back up to the heart. We use compression bandages, multi-layer wraps, or compression stockings, but only if the ABI is 0.8 or higher. If it's lower, we risk making things worse. Also encourage patients to elevate their legs above heart level. Even a few times a day can significantly reduce swelling. Now, let's talk about skincare. Venous skin is often dry and fragile, so moisturizers are essential. Keep the skin clean, gently pat dry, and protect it from bumps and scratches that could lead to ulceration. Wound care needs to match the exudate level. Use foam or alginate dressings for moderate to heavy drainage. Change dressings as needed to prevent maceration. Too much moisture can damage surrounding skin. Encourage movement. Calf muscles act like pumps. They help venous return. Encourage short walks, even heel raises. And finally, educate patients to avoid long hours standing or sitting. Simple actions like shifting position or flexing ankles can help. Now, let's turn our focus to arterial ulcers. These are caused by a completely different problem, blocked arteries. That means oxygen-rich blood can't reach the tissues, leading to ischemia and eventually tissue death. This is usually due to peripheral arterial disease, PAD, often caused by atherosclerosis, or hardening and narrowing of arteries. Diagnosing arterial insufficiency starts with the ankle brachial index, ABI. Anything below 0.8 is concerning. In fact, if it's below 0.4, it indicates severe ischemia. Additional tools like Doppler ultrasound or angiography help assess how bad the blockage is. Now, how do arterial ulcers appear? They're usually on the toes, foot margins, or pressure areas like heels. Punched out in shape with well-defined borders. Dry, pale, and with minimal drainage. Surrounded by thin, shiny skin that lacks hair. Cool to touch, and pulses are weak or absent. Pain is a big clue. It's often severe, worsens when the leg is elevated, and feels better when dangling down. That's a hallmark of arterial ulcers. Managing arterial ulcers is all about restoring blood flow. No amount of dressing or ointment will help if the tissue isn't getting oxygen. So first, refer to a vascular surgeon for revascularization procedures like angioplasty, stenting, or bypass surgery. And here's a crucial point. Do not use compression in these patients. It can worsen the ischemia and lead to necrosis. Pain management is important too, as ischemic pain can be intense. Keep the legs in a dependent position, meaning below the level of the heart. Avoid elevating the legs. When it comes to wound care, use non-adherent dressings to prevent trauma during dressing changes. Maintain a moist wound environment without overhydrating it. Avoid debridement unless the patient is revascularized and there's no infection. Dead tissue in a dry ischemic wound may be better left untouched if there's no infection. Don't forget about risk factor modification. Smoking cessation, absolutely critical. Control diabetes, blood pressure, and lipids. Prescribe statins and antiplatelet agents as needed. Now, let's look at the gray zone, ulcers that have both arterial and venous features. These are called mixed ulcers, and they're more common than we think, especially in older adults with multiple health problems. Here's the tricky part. Their ABI often falls between 0.5 and 0.8. Not low enough to be purely arterial, but not high enough for safe compression. So, what do? We take a balanced approach. Compression may be used with caution and only under specialist supervision. Revascularization should be considered first if there are significant arterial blockages. Once blood flow is improved, gentle compression can help with the venous component. Management must be individualized and collaborative. Nurses should work closely with wound care specialists, vascular surgeons, and the primary care team. Mixed ulcers are complex, but with proper coordination, even these tough wounds can heal. Let's talk about your role, because nurses truly are the heart of vascular ulcer management. You're not just applying dressings, you're doing comprehensive care. That starts with assessment. Check for pulses. Are they strong or faint? Look at the skin. Is it dry, discolored, or showing signs of infection? Is there edema or pain? Where? When does it worsen? Documentation matters more than we realize. Accurate records of the wound's size, depth, drainage, and response to treatment help guide the care plan and signal when something's going wrong. If ABI is 0.8 or above, you'll often be the one applying compression therapy and ensuring the patient is comfortable and responding well. If they aren't, speak up. Delayed care in vascular ulcers can cost lives. Pain control is another core task. That could mean adjusting dressings, elevating limbs, or making sure they get prescribed medications. And one of your most powerful tools, education. Teaching patients how to care for their skin, how to properly wear compression garments, and how lifestyle changes can prevent ulcers. This can make the difference between healing and a chronic condition. Lastly, know when to refer. If something looks off, worsening pain, infection, no signs of healing, get a vascular consult. You're the eyes and ears on the front lines. Here's where we shift from treatment to empowerment, because informed patients heal better. First and foremost, daily checks. Patients and caregivers should inspect feet and legs every single day. That means looking for new wounds, color changes, swelling, or temperature differences. Catching a problem early can prevent disaster. Next, skincare. Encourage them to keep the skin clean and lightly moisturized. Not too dry, not too soggy. No soaking feet, it weakens skin. If they're using compression garments, they need to be worn daily and replaced regularly. You can guide them on how to put them on, take them off, and check for any discomfort. Footwear matters. No more barefoot walking, even inside the house. Protective, closed-toe shoes only. And of course, emphasize sticking to follow-ups and medication. Missed appointments lead to missed opportunities for healing. Make sure they know, a small blister can become a major ulcer if ignored. Awareness isn't just helpful, it's life-saving. Let's bring it all together. Vascular ulcers can be stubborn and dangerous. They're more than just a wound. They reflect deeper problems with circulation that, if untreated, can lead to severe infections, hospital stays, even amputations. That's why your first step is always correct diagnosis. Is it venous, arterial, or mixed? Because treating the wrong way can actually make things worse. Nurses play a central role, from assessment to wound care, from managing compression to teaching lifestyle changes. You make healing possible. Your actions can stop complications before they begin. And your compassion gives patients strength through a difficult journey. So, stay vigilant, stay curious, and keep advocating for your patients. Together, we can turn chronic wounds into stories of recovery. Thank you for your time and dedication.